But I'll open it up for questions for our panel. I know that our time is not that long, but I would like to take any that you have. And please introduce yourself so that our panelists know the perspective you're coming from. Yes, sir.
My name is Joe Sheehy. I'm a congresswoman in Los Angeles. What's your research been on when a baby's getting to the end of the state of NICU, whether feed and grow is important in the NICU environment or important in the home environment? And because you had mentioned earlier about how this is somewhat new and it can be very profitable for a hospital, do you ever worry that it's abused, that hospitals will keep babies just for feed and grow purposes when they might be better in a home environment?
You can project.
Both. Go
Sure.
first and I'll.
Yeah, so sure, I think it's a risk. I think what we know about medical care today is that there's risks everywhere about overuse, sometimes underuse. It's a tricky one here though because we did try over the years through some, like in Philadelphia, through a very aggressive home care agency to transition babies home sooner, but it took more nursing care time. It's still on tube feedings and still on sometimes even incubators and things like that. It didn't really work out well in the long run. We couldn't find sufficient home resources to do that. Having said that, our goal is to get babies home as soon as feasible. And right now we're having a discussion locally about how much tube feeding should we do at home, because feeding is often one of the last things to develop in a preemie baby, ability to take breast or bottle without a tube. And certainly for certain patients who are not going to be able to take a bottle or a breast because of medical conditions, we send them on home tube feedings all the time. But yet there's some small risk to that. So we don't know the answer whether we should be getting the preemie babies home sooner. Having said that, though, there is a wide variability, I will tell you, among regions, hospitals, about how to do it. I'm not sure how much is economic, but certainly some is just comfort level in practice. So that's what I know.
I agree with all of that. We've certainly supported research in this question. Part of the difficulty is it's hard to come up with hard, sort of guidelines, because there are some things in medicine when we say, a child reaches a certain weight or a certain age, you do this or that. But as you can imagine, the variables here, the factors that play here are so great. It depends partly on the resources of the family, both financial and otherwise. It depends upon what kind of home visitation is available. It depends upon the kids' feeding style, how frequently they need to be fed, what kind of nutrition are they doing best on, et cetera. So there's so many things involved, and it's very hard to come up with hard and fast guidelines. I must say that a lot of times, while you can understand there are financial reasons why a hospital might want to hold on to a patient, also many NICUs face the other problem, which is that they're in such demand that there is a pressure to get kids out. So this is to a large degree, if you see folks in NICUs, whether you're talking about the medical staff, the nursing staff, the social workers, others, they're so devoted to the individual kids that the people who are actually making the decision, I'm fairly comfortable, are doing that in the best interest of the patient, which can be hard to figure out, but are really, I think, motivated by that rather than the hospital CEO feeling about bed census. So I do think we need to do more research in the area to figure out this, but it's always going to be a bit of an individualized kind of decision.
Thanks. Other questions? I will actually ask a question then, really, I think for the two of you. One of the things we've been talking about, you both mentioned you trained under one of the same mentors at Boston Children's, and one of the sort of chants that's been coming out from some of the community in our community is that we should get all the training out of academic centers and out of teaching hospitals, and I wonder as pediatricians if you have thoughts on whether that would make sense to do, or whether you think there's something that is important within your training as a physician to be in this environment where all three of these missions are going on. I'll give that to either one. So
I think we need to be training all kinds of healthcare personnel in some novel ways, and we shouldn't use only the academic medical center as the model for training of physicians or nurses or other healthcare providers. However, I do think that it has a unique role and one that I cannot imagine her doing without in terms of training both state-of-the-art clinical care, but also a way of thinking about things. We need to constantly have clinical caretakers, again, of all different kinds of professions, who are asking the important questions, who are thinking of the important questions, who, based upon their experience with patients' families, et cetera, are thinking about what are the things that we need to know that we don't know today, how might we learn those things, and then how might we implement them. And I think unless a fair number of people are trained in an academic center in which academic inquiry is one of the major missions, that the only way we will really advance medicine fully is having people who are trained top-notch clinical care, but also top-notch modes of inquiry, and that is where I think the academic medical center has a particular role.
Well, if there are no further questions, I would invite you all to thank our three panelists, and don't forget to say hello to Emily and Michelle and Craig on your way out.